Donc, il y a Rotimi de Los Angeles qui va faire sa présentation et ça aussi, ça va vous intéresser aussi. Donc, Rotimi, are you ready? You can start.
Okay, I will start. Okay. Thank you, Dr. Elm Turkey, for this opportunity. I apologize for being not appropriately dressed. I've had several cases in the operating room because I'm on call this weekend. But I wanted to share our work looking at the role of vaginal hysterectomy at the time of colpocleisis. So in clinical practice, we typically reserve colpocleisis for the sickest of patients. We tend to counsel patients who cannot tolerate extensive surgery due to underlying comorbidities for colpocleisis, or women who do not desire future sexual function. And while the rates of success are high in the literature and approach almost 100%, this procedure still has some significant risks, with one population-based study showing that you can have a rate of serious complications ranging up to 2%. So there have been prior studies that show that a lot of surgeons routinely perform concomitant hysterectomy at the time of colpocleisis. A recent publication put the number at almost 20%. And that brings to mind a question of why would we do that? Because typically a colpocleisis is a skin-based reconstructive procedure. It's supposed to be low risk for a woman who's pretty sick. And by adding a hysterectomy, you're transforming a skin-based surgery to a moderate risk procedure. So we asked the question of whether the added morbidity of a vaginal hysterectomy is exceeded by the benefit of potentially eliminating future risk of gynecologic malignancy. And we asked that basically because we wanted to see if there was any kind of clinical utility for hysterectomy or not. So what are kind of the arguments for proceeding with a hysterectomy? So if you do a hysterectomy, obviously the woman does not require future endometrial or cervical cancer monitoring, and you potentially reduce the risk for future malignancy. However, if you perform the hysterectomy, you do incur the added risk of operative time, possible vascular and bowel injury. And in the literature, there's no current evidence that hysterectomy at colpocleisis actually improves prolapse outcomes. So in terms of our methods, we looked at the California statewide database, which basically collects all inpatient admission data and surgical data for every patient that's within the California hospital system. And this allowed us to track each patient beyond their index case. And we specifically looked at cases that were done between 2005 and 2011, and we had follow-up ranging up to 2019. In terms of our analysis, we performed a number needed to treat analysis, looking at women who had uterine-sparing colpocleisis procedures. And we used that to calculate the number of hysterectomies that would need to be done to prevent one single gynecologic cancer diagnosis. Furthermore, we looked at regression analyses to understand what the risk of death was with this cohort. In terms of our results, we had 2,700 women who underwent a colpocleisis procedure during our time period, of which 23% of them had had a prior hysterectomy or had a concomitant hysterectomy at the time of their procedure. In terms of our number needed to treat analysis, we had 2,093 women who underwent a uterine-sparing or Lefort colpocleisis procedure. The mean age at surgery was 78.6 years, and we had follow-up ranging up to 10 years or more. We found that based on our cohort, 18 patients or 0.9% of patients who underwent a Lefort procedure basically incurred a gynecologic cancer diagnosis that would have been otherwise prevented by hysterectomy. And when we compare this to the literature, we found that this rate was significantly lower. The rate in the literature of endometrial cancer in similarly aged women is about 2 to 3%. When we performed a number needed to treat analysis, we found that at 3 years of follow-up, you'd basically need to perform over 1,100 hysterectomies to prevent a single gynecologic cancer diagnosis. At 5.5 years of follow-up, this number fell to 283 hysterectomies. And at 13 years of follow-up, it fell to 166 hysterectomies. So basically from the schematic, you can see that if a woman lives longer, the number needed to treat basically falls lower. However, if she has a short life expectancy, you'd need to perform a significant number of hysterectomies just to prevent one cancer diagnosis. So this basically made us ask the question of what the life expectancy looks like in our cohort. And so based on our actuarial data as well as hospital data, we estimated that the overall mortality in our cohort at 10 years was a third. So basically at 10 years of follow-up, 33% of our patients had died. So we used this endpoint to perform a multivariate regression analysis to select the patients that were at highest risk for having a cancer diagnosis as well as having the highest risk of death. And based on our regression analysis, we found that if a woman was younger at the time of her colpocleisis, she had a threefold increased odds ratio of basically having a new cancer diagnosis or death. And if she had one or more comorbidities, she also had a double-fold increased hazard ratio of having a new cancer diagnosis. When we ran the model for the risk of death as the outcome variable, we had similar effect sizes and similar confidence intervals. So in terms of our takeaways, we found that the overall rates of gynecologic cancer diagnoses in patients who had a uterine-sparing colpocleisis was very low. So 0.9% of our cohort developed cancer at follow-up, and this is much lower than previously published rates, which show that the rate was about 2 to 3%. We also found that concomitant hysterectomy does not appear to confer a mortality reduction benefit. So for our younger patients who underwent colpocleisis, they tended to be sicker and they tended to have decreased odds of survival, which is probably why they were counseled towards colpocleisis to begin with. So we would argue based on our model as well as our number needed to treat analysis that they probably would have an increased morbidity from a hysterectomy. So you should probably avoid a hysterectomy for these patients. For our patients who had a greater than 10-year life expectancy, we found that they lived longer. We also found that they had the lowest risk of having a gynecologic cancer diagnosis. So we would argue that based on our results, that they also are at the lowest risk of having a reduction benefit from a hysterectomy. And because they appear to live longer, you could argue that there's no need for a hysterectomy as well. Obviously, this data set is pretty limited in terms of how granular it is. We also don't know what the patient level risk factors were in terms of their risk of developing a gynecologic malignancy. We also don't know what the screening history is for these patients. So we don't know whether their gynecologist gave them ultrasounds or did biopsies before surgery. So this could be a pretty selective data set, and it's hard to tease that out. So in clinical practice, what would I do? I would typically, counsel the patient about performing a colpocleisis without a hysterectomy. If the patient has known risk factors for cervical or uterine pathology, obviously I would screen them with an ultrasound and an endometrial biopsy if indicated. But I think based on the data, at least in this setting, it's safe to say that for a younger patient at time of colpocleisis, meaning that a younger patient is less than 70, if they are sicker, then you can consider avoiding hysterectomy in totality. So with that, I'll take questions.